afternoon. I'm Francis Levy. Ed Nersessian and I are co-directors of the Philoctetes Center, and welcome to Addiction. Before we begin this afternoon's panel, I firstly want to thank all of our panelists for donating their time to the event. That is really amazing, you know, and it's amazing that people are excited to be here at Philoctetes and to join with us and to contribute so much energy and enthusiasm for our particular organization. The art you see on the walls, I always say this, but I'm very proud of the show. Hallie Cohen curated it along with Adam Ludwig, and it's attendant upon the 6 roundtables we did on aggression. So we have, in short, it's really kind of a literal view of aggression. You see Alexander Gibbon's portraits of the Rwanda war testimony, people who were involved in the testimony of Rwanda. And then on the other side, you see Margaret Rollicke's stick-ons. And so you have a kind of very abstract view of aggression. And then here you see Robin Chews with more expressionistic figurations. But we went from the documentary to the artistic in this presentation. And I think it's I personally think it's a very astonishing gathering of artistic works. And it's interesting that out of a theme in which there's so much ugliness, that beauty can emerge from it also. What I really want to say today is that we're very excited about 2 other events coming up. On May 11th, we are doing the Je ne sais quoi of taste, food for thought. It's a benefit for Philoctetes. It's going to be at the French Culinary Institute, actually, has donated their space. And Niels Noren, who was on our 5 Senses panel, has really been, along with Mark Mittner, these 2 Philoctetes panelists have been behind this particular project. Now, the tickets are $250 a person, but it is a spectacular event. And the French Culinary Institute is a bizarre institution. It's a building on Lower Broadway that has a very deceptive and innocuous appearance. It looks like a restaurant, but inside it, it's more like a hospital for food. It's got amphitheaters. It's like a medical school where they triage meat. They have urnophiles. You know, I mean, I've been there twice now, and I'm not. You know, Ed knows it's very difficult with me to get me interested in these kind of things, but I can't leave the place. It's fascinating, and we have Philip Pearlstein, the painter, a number of well-known chefs, and there's a lot of activity around this particular event. So if you want to donate to Philoctetes and at the same time you want to gratify your palate, it's going to be an evening totally of eating and listening, and you'll emerge hopefully full of food and full of thought.
It's 100% tax deductible, but the Culinary Institute is donating that.
Yes, it's 100% tax deductible. We won't deal with the indigestion problems. And then we have another benefit coming up. Our Life in Poetry is a very popular poetry program that's been at Philoctetes. It's been run by Mike Braziller. And Ed Hirsch, who did Robert Frost, and Marie Ponceau, who did Gerard Manley Hopkins, and Eamon Grennan, who had talked beautifully on Yeats, and other poets, are coming to read their own poetry in support of Philoctetes. And those tickets, it's on June 2nd, and those tickets are $25. So now, without further ado, I am pleased to introduce Cristina Alberini. Cristina Alberini, who I've gotten to know well over the past few years, is an associate professor of neuroscience, psychiatry, and structural and chemical biology at the Mount Sinai School of Medicine. Her current research interest is in learning and memory. Cristina will moderate this afternoon's panel and introduce our other distinguished guests. So take it away.
Thank you very much, Francis. And thank you for giving us the opportunity to be here today to talk about such a hot topic that interests many, many people, I'm sure. What I'm going to do is just briefly introduce the panelists. We are fortunate to have, as usual in the roundtables of Philoctetes, panelists with different expertise. So it's going to be interesting to have different point of views on this issue. Stephen Delafield, right here next to me, received an MS from Hunter College with a specialization in alcoholism counseling. For the past 15 years, he has worked for a number of hospitals and agencies, including Beth Israel, the Abraham Residence, and currently the Parallax Center, a privately run clinic for drug rehabilitation, where he provides both individual counseling and group therapy. William Gottdiener is director of the Addiction Studies Program at John Jay College of Criminal Justice of the City University of New York, where he is also tenured associate professor in the psychology department. He focuses his research on 3 topics: the psychodynamics of addictive disorders, effectiveness of psychological treatments for addictive disorders, and clinical training in addictive disorders. Bill is also the North American Associate Editor for the journal Addiction Research and Theory. In addition to his academic work, he has a private practice in addiction psychology, providing individual psychotherapy, couple psychotherapy, psychological testing, and clinical supervision. Bill received a PhD in clinical psychology from the New School for Social Research and completed a postdoctoral substance abuse research fellowship that was funded by the National Institute of Drug Abuse. And on my right side, Scott Russo. Scott is an assistant professor in the Department of Neuroscience. We are working in the same floor at Mount Sinai School of Medicine. His research is focused on understanding how the brain adapts to stress and drugs to guide future behavior that are relevant to addiction and depression. Scott obtained his PhD in psychology from CUNY Graduate Center and then completed a postdoctoral fellowship in psychiatry at the University of Texas Southwestern Medical Center. He has trained and still collaborates extensively with Dr. Eric Nestler, who has just moved from Texas to Mount Sinai. We're all very fortunate to have him, and he's the director of the Brain Center at Mount Sinai. I've been introduced by Francis, so I don't need further introduction. I'm at Mount Sinai. My lab is working on memory. And I'm just going to give you a very brief introduction about addiction and then ask our clinical panelists to start and telling us about their work, what they find in their clinical experience, what problems, and how they go about to solve those problems. We all know that addiction is an obsession, a compulsion, or an excessive psychological dependence on something. And that can be drugs of abuse, alcohol, but also food, computers, sex, gambling, many other things. In the clinical experience, I'm sure they see very different types of addiction, so we're going to get to that. It's very interesting that addiction is so interrelated with a number of other problems, such as mood disorders, stress. And my interest in it is actually to understand how memories contribute to the behavioral manifestation of addiction. So without further continuing giving you the introduction, I'm sure you know and you experience what are the problems related to addiction by either hearing from it or knowing people or by personal experience. So I'm going to turn the table to our clinical experts. Maybe Bill, if you want to start.
Okay.
and please feel free to add something about yourself
Sure.
and what you do.
Yeah.
To further introduce
so maybe
yourself.
that's probably the easiest way to start. And if anybody has questions, feel free to interrupt me, ask questions.
We actually have
oh, okay. I'm sorry. Okay.
We'll let you guys go. And then
Okay.
we'll
Never mind. I approach addictions from both research, training, and clinical perspectives. I got interested in addictions actually in graduate school, but it was sort of a side interest. And it didn't really occur until I got on my clinical internship. In fact, I thought addictions was one of the most boring and uninteresting topics that I could possibly study, and had no formal training in it. Something I'll speak about that's still an issue these days. And just happened to be assigned a patient who was an alcoholic, and then had another patient assigned to me shortly thereafter who was recovering from marijuana dependency, to use that term loosely, and began to become very, very interested in it. Then the first job I got out of graduate school was at a therapeutic community for substance abusers. That got me even more interested, and simultaneously I happened to get a job working as a research assistant at a place called the National Development and Research Institutes, which is a large social science drug abuse research organization in the city. It has a lot of funding from the National Institute on Drug Abuse, National Institute on Alcohol and Alcoholism, so on and so forth. So I began to become very, very interested in drug abuse, and found that I worked well with drug abusers, and liked doing treatment with drug abusers, which almost none of my colleagues enjoy doing. And I still find it very difficult to find colleagues who are interested in working with drug abusers. I was also very interested in psychoanalysis, and it's seen trying to understand how psychoanalysis and psychoanalytic theory, psychoanalytic interventions might be useful for people with substance use disorders. And I was sort of very much an oddball in my postdoctoral fellowship, because I was definitely the only one really interested in psychoanalysis. But it was a very eclectic, sort of multidisciplinary postdoctoral fellowship, so they thought I was fine. Since I also did meta-analysis research that had nothing to do with psychoanalysis. The way I got more and more immersed in tying the two together, my research and my clinical work, was really through the self-medication hypothesis of substance use disorders. And the self-medication hypothesis is basically a model of the development and maintenance of substance use disorders that was developed by Ed Kansian, who is a psychoanalyst who's up in Boston. And he published the first article on that in the American Journal of Psychiatry in 1985, and has subsequently published a number of other studies. And a lot of my research really comes at the self-medication hypothesis. And I think about clinical work from a self-medication perspective, which essentially, and this is going to be a boiled down version of the self-medication hypothesis, because I think it's multiply layered, but the boiled down version is that unpleasure leads to a need to defend against that unpleasure. People with substance use disorders have some sort of deficiency in defense mechanisms, or an inability to deal with unpleasure. At some point, they serendipitously find that drugs work, and they keep returning to them because they keep solving that problem of dealing with unpleasure. And unfortunately, the drugs the effects are transitory or transient, and they don't have a long-lasting effect, and the person continues to go to them over and over again, to the point where it almost becomes part of their character. And at that point, the person continues to use the drugs, and now is creating a problem that creates more unpleasure. So they need to go back to the old methods to get rid of the unpleasure, which is the drugs, but ultimately that creates more unpleasure in the long run. So I find that that's helpful, and that patients actually think about, a lot of patients know about the self-medication model, or they know something about it, and they often say they self-medicate, and it can be a useful way of talking to patients. And then in terms of trying to understand it from a research perspective, I'm trying to understand problems in defense mechanisms, what are the deficiencies in defense mechanisms, how do we try to restore those deficiencies. And one of the ways I work clinically is my approach to substance abusers is really to have as open and flexible an attitude as possible. Essentially, to use the catchphrase, trying to do what works for the patient and meet the patient where the patient's at. So I will see patients who are using. On occasion, I've seen patients who've come into my private practice in my office who have been intoxicated. That's not something I encourage, but I do allow it if it happens. And with the ultimate goal, usually that abstinence is the best outcome for most people, but it's not an outcome necessarily always achievable at first. And I often do, more recently, have integrated something called network therapy into my practice, in which I combine individual psychotherapy with the support of usually a family member or a friend who will come in one session a week and help the patient really in their efforts to become abstinent and maintain abstinence. So I don't know if I should go on. I could go on, or if you want to take it away and talk about what you do at this point.
So I have a question, by the way. So the beginning of this desire to start using some self-medication is an unpleasure.
That's according to self-medication. It's to deal with unpleasure. It may be to seek pleasure, but it's to deal with ultimately. What's that? Any sort of. I'll clarify. Unpleasure. Unpleasure. It's really more of a psychoanalytic term, but I like the term because it's a global term that refers to any sort of unpleasant emotional or physical experience. So anxiety, distress, dysphoria, something that's just not going to be enjoyable.
So this could be highly dependent upon other psychiatric disorders such as depression and bipolar disorder.
Absolutely. Did I answer your question? Yeah, okay.
Maybe, Stephen, do you have something to add to that, or talk about what is your experience and take on?
Yes. Well, I just want to introduce myself as a recovering alcoholic, and I work also for a substance abuse clinic, and have been doing that for the last 15 years. The reason I mention my own addiction is because it was an important. It was what stimulated me to obviously to get into the field of addiction. When I was drinking, the whole world was my problem. My problem was the world, and my solution for it was drinking alcohol. It was just that simple. And somewhere along the line, I switched. I became aware that, and I didn't know this at the time. I became aware that the problem was the drinking, and the sobriety was the solution. Now, how that happened, I can't tell you because it's a mystery, but it did happen. And so my subsequent career was to find out why it happened. It is plain to me, and I don't mean to pass myself off as a learned person in this field at all, appearances notwithstanding. People drink because, or use addictive substances in order to solve problems. You put it in a slightly different way, but that's the basic assumption, and so. And each person who I see in my work has different problems, and so I have my main approach is well, it's different for each person I see. Is the point that I'm trying to make. What I do, therefore, my basic approach is to listen. I'm a listener. I try to figure out who the person is, where they're coming from, and what their reasons for drinking is. And there are certain. It's as I just said, it's different for every single person that I've seen, but there are certain similarities which do stand out, and one is lack of self-esteem, lack of self-worth. You might say lack of self. There is a whole branch of psychology called self-psychology, and its basic premise is that addictive people lack a sense of self. So that's one approach. Another aspect of that is that I'm not okay. I'm less than okay, and one thing that I do is to try to create a safe atmosphere and create a relationship with the person, with the patient, and go from there. I'm not addressing myself to the other physical aspects of addiction, because that's something which is a whole other aspect of this thing. Where the clinic that I work for is very one of the components of the treatment is medication, and the idea is that the person who is recovering is depressed, unable to sleep. They need sedatives because their nerves are fighting back from addiction. All sorts of different things, and also we use in the clinic certain blockers, which I think is going to be addressed by your idea of memory, because the medication simply blocks the high. In other words, it blanks it out. So,
what's the medications?
Well, one example would be Revia. In the case of heroin addiction, you can, or Vivitrol is another one. A third one in that particular addiction is Suboxone, which is a sort of a maintenance drug, but it's less good for certain people because it is an addictive substance itself,
like methadone.
Like methadone, yeah. So if you do that, you have to get off the. You just postpone the getting off. If you can get off the addiction by the blocker, you're obviously doing much better. Then there are other things like for alcoholism and abuse, for instance, which makes you sick if you drink. It's a strong incentive not to do it. You get very sick to your stomach. So those are some of the physical things. I don't have anything else to say, really. I'd like to hear what everybody else has to say, and then I would like to come back into the discussion. Thank you.
Sure. But I just have a question.
Of course.
How do you see, in terms of the effectiveness of therapies, in your experience, and maybe it's different in different types of cases. Do you see that the psychological therapy works better or more effectively in the long term versus the pharmacological, or is there a combination? What is that is seen in the clinical?
Yes. The patient needs to want to get sober, to want to get free of the addiction. If they don't, they're in the wrong place, and they're not ready. And many of the patients who come to me, for instance, they're obviously ambivalent about it. Part of them wants to recover, but on the other hand, I mean, usually that's a rational thing, but part of them is pulled to repeat the experience and not to recover. So they have to want to. That's the first thing, and in fact, the successful people have already stopped drinking. Or using the drugs when they come there. If they haven't, you've got a big problem. They really need to be in detox or in a 28-day rehab program to have the experience of getting free of the addiction.
So does that mean that if they are not free from the use of the substance, the therapy is not successful? This is what you are implying, or I don't know in your case, if that's meaning there is a very low rate of success unless there is already a process started in eliminating whatever is the substance that is connected to addiction. Is that what?
Well, I think that I don't know if you want to jump in and say something.
No, go ahead.
I mean, I think part of this, my answer is going to be sort of a philosophical perspective, in that goal of sobriety, I think, is probably the safest and healthiest outcome for most people. But it's well known, and there's a fair amount of research to support this, that a lot of people don't take to sobriety or abstinence at first. And there's a whole movement within the United States as well as outside of the United States called the harm reduction movement, which some people interpret as let people use and just let them use, but not endanger themselves as much as they normally would, or endanger society as normally. I don't think that's not my interpretation or take on harm reduction. Harm reduction is the essence is to reduce the potential harms caused by substance abuse to the individual and ultimately to society, but that. Taking that into a psychotherapy or treatment perspective, probably the classic harm reduction approach is methadone and buprenorphine, in which the goal there is to make treatment safer, deprive the person of the opportunity to hurt themselves as much by being an opiate addict, and giving them a way of ultimately titrating off of the methadone itself and the heroin or whatever else they might be, or whatever opiate they might be addicted to. And I think it depends on the context, too. If you were treating somebody like I do right now, at this point in my career, exclusively in private practice, I think as a private practitioner, you have to make a decision about who you're going to take into your practice. I do take people in who are active users, but I have to assess how bad they are. And that's not always easy to do, but I am willing to see people who are active users, and I am willing to see people who want to become controlled drinkers. that's certainly not a popular outcome in the United States. If you go to the UK, to Canada, or Australia, controlled drinking is actually taken very seriously. In the United States, it's not. There is an organization called Moderation Management in the United States that tries to sponsor and discuss controlled drinking as an option for people who are alcohol abusers, but probably not alcohol dependent, and they even say so in their promotional materials. I agree with you that people need to want to stop using, and I think that's the difficulty that we as clinicians face, is how do we get them to want to stop using? Because in my experience, a lot of people come in saying they should stop using, and I say to them, that's different than wanting to stop using.
How do you get you mentioned a very interesting thing about this, the lessen the self-destructive, but what if the goal, I mean, it seems hard to avoid the sort of larger intrapsychic issues that what you're talking about proposes. Because say that the goal of the particular patient is to do something self-destructive. Say that's what he wishes to do, then you're depriving him of that particular goal by lessening the harm he's doing to himself by taking the methadone.
Yes, but a lot of people then just go out and use.
I mean, a behavioral approach just deals with behavior. So you say you lessen the harm, but maybe I want to harm myself. I like that.
Well, it's true. So then you would be trying to address that. That's what I would do. I mean, I would try to address the intrapsychic process. I look at substance abuse as someone who coming in, the issue of ambivalence is prevalent, and they're in conflict. And part of what they might want to be doing is to harm themselves. Part of what they're doing is to rescue themselves, and so I think it's important to try to unpack that if possible and try to understand it. But at the same time, if you have someone who's dangerously harming themselves, you can't necessarily wait to try to understand. Sometimes the understanding also will come after getting somebody to reduce their use or to stop using.
There's a branch of psychology that sprung up. I think it was popular here in New York maybe 10, 20 years ago. Bill Miller from the University of Mexico, motivational interviewing, which kind of goes along that, where you...
What's it called again?
Motivational interviewing, where it's called motivational interviewing, and it's been shown in research to be very successful for long-term abstinence, especially from alcohol.
It's actually the results, I think, are mixed from the latest meta-analysis.
Is it mixed? I haven't kept up with it recently, but it focuses in on that ambivalence that you were talking about, and getting the patient, usually in a situation like an emergency room setting after they've just had a particularly bad car accident after drinking a little too much, and in a very empathic, non-judgmental way. The key is to really get the person to admit that there is kind of an underlying issue that they need to change the behavior, and they don't go at you at complete abstinence. It's more of getting you to change small things first. Can we not drive when we're drinking, so we can at least stop the car accidents and potential deaths, and then it kind of snowballs from there.
Mm-hmm. But your question about prognosis, so you complicated the question, but you didn't answer it.
In terms of...
In other words, the question is the prognosis better if somebody comes to treatment saying, I've decided to stop, as opposed to somebody who comes to treatment and says, I think I should stop, but I want to work with you to see if I can stop. So
I would imagine the prognosis, as I said before, is probably best if the person has already begun to stop. A lot of people do already stop before they even go into an inpatient facility. But then there's also plenty of evidence that people will resume again. I think, tell me what you know about these statistics, but I think overall, of the people who actually go in, and these statistics are actually hard to measure, people who start with any kind of psychological treatment. And I think even any sort of the few pharmacological treatments, overall success rate 5 years out is about 30% of the people who actually start. So it's not great anywhere. So there's the prognosis is pretty crappy for most people, but that's hard to assess because people will relapse. People will go back and try again. And there's also some evidence the more they try, the better they will get in the long run. So where you're catching them in the cycle of use is also.
I just want to add to that what Francis was saying about the self-destructive things. One of the most difficult people to treat are the ones who believe that they're doing it because of their willpower. That's absolutely hopeless.
Right.
And
doing what because of the willpower?
Stop using substances. They think that they're going to overcome them by the use of willpower. The thing is that they make that decision on Tuesday, but then on Wednesday their willpower suddenly changes because they don't have any appointments, and they don't have any group, and they don't have any meetings, and they don't have any support system, and so their will is to use. So, I mean, what a silly thing, willpower is. So that's one thing. The other thing that I just want to say is that in my clinic we do definitely say that you have total abstinence is the answer. I know that there are these other approaches, but the idea from the psychological point of view is that you can't even address your problems if you're using. You can't address the problems of even why you're using unless you stop using, because your mind is in a different mode. You're using self-medicating, or you're using to solve your problems, and you have to stop using first in order to address those very same problems which are causing you to use in the first place.
Yeah,
right. So it's a little complicated.
Yeah, I mean, I think there are some people for whom that's absolutely true. I don't. At least in my clinical experience, that has not always been the case. I think there are some people, for example, I mean, one of the things to get at prognosis issue, clear psychopathology always makes the prognosis worse, and there's lots and lots of evidence for that. But I've treated some patients with trauma who are also substance abusers, and if I didn't address the trauma symptoms, then the substance abuse, at least in my opinion, would just continue to go, because the substance abuse was medicating the trauma. By addressing the trauma and reducing that pathology, the person lost interest in using.
So there seems to be a couple of things emerging. One is the effect of the substance per se, the biological effect of the substance. When a subject is under the substance or is using, his brain is hijacked, and that actually is a very persistent effect. So that's why probably they need to be off the substance and the more they stay off, the better is the hope for resolving the problems, even though there is the issue of relapse, potential relapse, because of the lack of the substance and the feeling of going back to the pleasure, or blocking the displeasure caused by the withdrawal symptoms or sign. So changes in the brain that maybe Scott can comment about, as well as others, pathologies, like traumas or stress.
Cristina, before we actually go on, I wanted to just ask you about that, because you've done some experiments emphasizing the biology of this.
Right.
What can animal research, like you've worked with rats, am I correct?
Right, yes.
So that the work with rats, what can that tell us? Why does animal research reflect on these addiction problems?
Right.
I mean, I hope I'm not interrupting the.
Right. Either Scott can start or I can start. We both address this problem from different point of views, meaning other types of pathologies, such as, for example, anxiety, stress, depression, how they interact with addiction, as well as, in my case, how memories and persistence of the feeling of how the drugs or the substance makes us feel is contributing to the addiction and to the relapse and to the cravings. So I will let Scott start, and then I will get back to the memory and the persistence.
It's interesting to hear the clinical perspective, and I think Cristina would agree that when you're at a laboratory bench and you're doing these studies, they can be difficult to translate, and it's important to do these kinds of things so that we can begin to translate what our findings mean. One of the most persistent findings that we have in addiction neurobiology right now is that stress and drugs can similarly change the structure and function of nerve cells within the brain, within brain regions that regulate mood. So for example, how you experience pleasure. Memory is another big one. And so if you think about when you're most at risk for relapse, it's a lot of times when you're under stress. And it's interesting that stress does very similar things to your brain as drugs. And so that may be some type of trigger, a biological trigger that can lead to relapse in that behavior. And so I think the basic biology, to get to your question as well, the basic biology and understanding what these types of stimuli can do to the basic biology can help us to understand two things: how we can develop medications to target those things to reverse them. So that would be the big one. That's mostly what I would say our findings directly translate to. But also, there's some recent studies using brain imaging which shows that the effects that you get with, say for example, an antidepressant medication or Suboxone or other medications used to treat addiction can be very similar on the functional imaging as psychotherapy. So when you combine the two, you get the greatest effect. So you can see how maybe psychotherapy or social support or spirituality could lead to a change in how your brain functions that can be effective in treating addiction.
But how does like a rat is not a person. A rat, we have consciousness, and I always associate addiction with consciousness. But when we first started to talk about your experiment, you introduced a whole other thing, because a rat obviously doesn't have the consciousness of a person.
It doesn't, but there is a certain level of consciousness. And you can see this as a different levels that goes from the smaller or less developed creature to humans.
Yeah.
At least we are human-centered, so that's what we believe, right? But certainly there is a certain level of consciousness in all the creatures. And so rats are not that distant from humans in our view.
But also,
empirically proved lately.
Also, I think you need to think, I mean, the question is, from the neuroscience side, is what they do to get these animals get addicted.
Right.
There is an outside agent who's addicting them.
Right. So we're going to tell you.
In the humans, they have consciousness, self-consciousness, so that's why they go and buy it themselves.
Yeah, but actually,
rats cannot go buy it.
But they do, right?
It's because you provide it to them.
They don't go buy and pay money, but there is something else that they do.
Once you get them going, obviously, once you addict them, then they're going to want to go after it time and time again.
Exactly.
It's interesting. I mean, obviously, it's a different kind of consciousness, but you can put an animal into a cage with two levers, and those levers will trigger either an infusion of nothing or an infusion of their drug. And the first experience they have usually is to accidentally bump into the trigger that gives them drug. And it doesn't take very long for them to learn that that's the pleasure trigger. And so they very actively press that lever. So there is some component of choice there, but not the same level of consciousness that you're referring to, obviously.
And I'm not so sure you would talk about choice in the way you would talk about choice in humans. If once what I think was a very nice way Cristina described it, once the brain is hijacked, that brain is going to keep going to be hijacked and hijacked again. So whether that's choice in animals is another matter.
Exactly.
Well, yeah, I just wanted to say that the business of choice is very interesting, because when you're an addict, you really don't have any choice. And one of the
that's
things...
the hijack is a good term.
It's a beautiful term. I woke up just when she said that. The thing is to restore... for instance, when I started out to say that my problem was the world and I drank was the solution, I didn't have any choice. At least I wasn't aware of any choice. And so one of the therapeutic things is to establish the possibility of choice in the patient. From the psychological point of view, you give them the choice. They think that the drug is the only way. The other point that I want to make, which from what you said, is that the drugs are a short-term solution, a short-term turn-on, and it's very powerful because it's now. I want it now. I want the good feeling now. And that in this way, we're not at all different from rats, right?
Right.
He wants the immediate pleasure. The whole concept of a psychological approach to the thing is that you give up the immediate gratification of now, but you, in terms of a long-term better appreciation of your problems and solutions. So there's a difference in timing there.
Yeah. So this compulsion and obsessive wanting, there is no even will. It's just an automatic response at one point to get the substance. We believe, or at least the part that we are interested in, is that involve heavily long-term memories. So how strongly we remember about the good effect of the drug or the bad effect when we are addicted and we want to avoid that is really an important contributor to addiction and relapse. And in fact, many addicts, they relapse more frequently when they encounter something that reminds them of the effect of the drug.
Yes, yes.
So they can be away and in a rehab, but then they go back to the same place where they used to use the drugs, and they relapse right there. They did very well before when they were away from these cues and something that reminded them of the effect. But then they go back, and these cues and memories trigger the craving and the relapses. So this is what we are interested in, because what we do is to look at the persistence of memories and how we can interrupt that. And there is a relatively new research in the memory field that shows that established previously from old memories can be disrupted if they return to mind, if they are recalled. There is a time window immediately after this recall during which we can disrupt these memories. The memories become fragile. And if we do something in this time window, we can actually disrupt them. So we applied these ideas to the drug-induced memories. And the way we do that is a little different than the lever pressing and self-administration type of approach. It's called place preference. And we can relate to that. If we get in a very good mood and in a very good state in a place, we would like to go back to that place. So the context and the surrounding of the pleasure is a trigger for us to go back to that place. So these rats, they get a drug and they are confined into a room for a few days, and then they're given a choice after these several experiences, good experiences with the drug, to whether they want to go in that room or in another one. And they develop this place preference, this preference for this room. And that is how we measure the memories, which is related to the people going back to the same places where they have experienced the pleasure of the substances. And we look at how we can interrupt those memories. So we recall them, and then we give certain drugs that block basic biological function in the brain, like the production of proteins for a certain very brief amount of time, or blockers of certain receptors. Obviously, the mechanism are under investigation.
Is it short-term memory you're working with there?
No, long-term memories.
Long-term.
So, in fact, the problem is that these memories are too long-term.
Right.
They are never forgotten, basically. And so this is what we want to do. We want to interrupt the storage of these memories. So we want to recall them and get rid of the intensity, of the intense representation of
Does it mean
memories.
eradicating the memory entirely?
They forget completely.
Oh, no, really? Wow.
They forget completely to associate this context with the drug. They do. Now, what the drugs we use to do that is they cannot yet be used in clinical settings, but we're getting there. We're slowly understanding which ones can work then.
What kind of drugs, just out of curiosity?
So the ones that we use, because we know that they interrupt the memories, the long lasting storage of the memories, those are blockers of protein, of making of proteins, protein synthesis. And those are very toxic. So they cannot really be used in clinical settings in humans. Some of them are used in oncological cases, but as you can imagine, I mean, those are very non-approachable cases in other ways. So we can do better than that. That's what I'm saying. But the principle is clear. That can happen. We can disrupt these memories. And actually what we see is that by disrupting these memories, these rats do not undergo withdrawal, which is...
But then it's like a lobotomy, though, isn't it? You're taking a part of the potential.
That's an interesting question. Are we really, taking away something that is so important for our life? And I have to say that this approach is very memory specific. So it's specific for that memory that is recalled. It does not affect the other memories that are present in the individual. So it's very selective. However, there is the question.
A drug that selectively undoes memories pertaining to the addiction experience?
Yes.
And doesn't remove any other of the pleasure centers or any other memories of pleasure?
Other memories, they are intact. If they are not recalled, they are not available for being disrupted.
So these rats continue
selective.
to have sex and
Right.
all the other stuff?
All the other pleasures. We didn't test that yet, but we should, yes.
Do the memories come back? Do the memories come back once the drug is discontinued?
No. In fact, this is an intervention of a specific mechanism that is the restabilization of this memory. So after these memories are retrieved, they become fragile for a certain amount of time, which is not even that long, relatively short time. But then they become stable again and insensitive to manipulation or disruptive manipulation. So the selectivity is that the memory is in this active state because it's retrieved. And the disruption given by this pharmacological approach show actually that even if they are tested at much later times, they don't have the memories. That they're gone. Now, when I say they are gone, I don't want to say they are erased, because even though some people use that term, we really don't know if somewhere some part of the memory is still there and is just not expressed. We don't know that. But certainly when we test them, they don't show any memory.
So they're not showing really a procedural memory, because you can't really ask for an explicit memory from a rat, right? Or declarative memory.
I think it's
these
similar.
are sort of related because they use the same part of the brains as explicit memories. So just to give you a little bit of explicit and implicit, those are different types of memories. Explicit, like declarative memories, is memories of facts, people and things, the memories we talk about, the memories of our lives,
has a
of
temporal
who we
component.
are. Right, as a temporal component. Right. As opposed to implicit memories, these are the memories of how to do things, how to tie your shoes, how to play piano, how to drive, how to ski, and so on.
This is similar, though. There's a correlate or an example in human treatment right now for post-traumatic stress disorders and for phobias. And what they do is, I think they've tried injections of cortisol, a stress hormone, propranolol, a beta blocker, yes. I believe. Yeah. And what they do is they re-expose, you probably know more about this than I do, and give the agent. And it's very effective in treating post-traumatic stress disorder and simple phobias. So it's similar. There isn't anything, I think, equivalent right now going on in humans for drug addiction, but
right, because
it's close, hopefully.
At the beginning, hopefully, yeah.
Yeah.
Well, it's good for traumatic events that are fairly isolated and unitary. I mean, very complex experiences. I would imagine, traumas that have occurred over a 15-year period are probably not as easily treated because you can't expose the person to a number, rich enough.
Sure. I mean, all those are issues that have to be addressed because in humans, conditions is very different. They are much more complex, perhaps long. The experience is much longer lasting. What we do in the experimental animals is always much more limited. Clean, I would say, but obviously limited.
I was curious, if you take those rats whose memories you've erased, or no, I shouldn't use erased, memories you've made fragile, can you retrain them to become addicted faster?
I don't know if they become addicted faster. Yes, that's a good question. We didn't try that yet, but certainly they can be retrained to become addicted. That's no question.
Because I would imagine if the lag is shorter, that would suggest that there is some sort of memory stored that gets reignited.
Residual, yeah. I mean,
the way that would translate into my work, which is psychological rather than whatever else, is rather than memory, it's the way I would think of it is habit.
Yes.
And you develop certain habits which, like a cow going to pasture, will go in the same rut, and each time the cows go to the thing, the rut gets deeper, and so the habit is reinforced by the repetition of it, obviously. So one of the things that we would suggest is substitution of pleasures and activities, and we're very. I'm very strong on that. I mean, to disrupt when you want to have a drink, for instance, instead of doing that, if you go and play a game of tennis, obviously, you're not going to, you're not going to be thinking of the drink while you're playing the tennis. Or if you swim, for instance, you're not going to be anxious in the swimming pool, and anxiety might lead to drinking, so forth, so on. So it's you create new habits. But as far as what interests me in what you're saying, as far as I'm concerned, the old ruts don't disappear. It's just that you create new little paths, new pathways,
choices.
So yes, so that you always have to be mindful that it's like this table. If you're going to, you can very easily slip back over to the left where the other rut was, instead of going this way, which is a different choice.
That's why these new therapeutic ideas based on disrupting the old negative habits is to take them away so that it's more difficult to go back to them. But yeah, I mean, it's obviously right now we have to remind ourselves that is in the animal models, is in the research field, and there is a lot that has to be done from here to humans and clinical settings. And a lot contributes to that with other types of pathologies, right, or stress or traumas that you were mentioning.
You mentioned The two things you mentioned when you were talking about context changing was both of them were exercise related. One was tennis, one was something else. But the question is, exercise is very effective for treating depression and other psychiatric disorders. How much have the two of you experienced exercise as being a good way of stopping the addictions in your practice?
Bad, because most people don't want to exercise.
Have you ever seen it to be effective, though, for people?
Yeah, it can be helpful, but they have to have an interest in doing that and maintaining that, and that's to me, that's where the issue comes. It's not that the exercise in itself. I mean, a lot of people, I get some patients who say, "Yeah, the exercise makes me feel better. I'll continue this." But and probably 80% of the people in this room probably have the same attitude at some point, and yet their gym membership is collecting dust someplace. So regardless of knowing that, even having the experience. Getting them to do it is a whole other thing. People say, I don't have the time, whatever, and it may all be true.
There are other things, though. It's not only, there are other things. I mean, when you're drinking, for instance, I'm using that as a generic term for addiction, you're spending a lot of time doing that, right? When you stop doing that, you've got huge amounts of available time. How are you going to use that time? That's where the thing of substitutes comes in. Some people go to AA meetings, for instance, and they go all over the city and they go to different AA meetings. Some people start to read. They didn't ever had the time to do that. Some people go to the theater. So some people do so it isn't. I think exercise is excellent because it actually lifts the whatever it is, those little endorphins that run around. But it isn't by any means one develops a sort of a new attitude of curiosity in life that you didn't have when you were sedating yourself constantly, so that you become awake, and therefore whatever you're interested in, you're going to be. And you can pursue that. So I don't know about just exercise thing, collecting dust. If you're not interested in exercise, no, you're not going to do that. But you're going to begin interested in something.
Sure, but I think one of the things that I see that comes up, and this goes back to even some research paradigms that are very popular in the drug abuse research world these days, where they give, sometimes to do with rats. I don't know if you've done this with your research, where it's called a delayed discounting task, and you can do this with people. I've done this some research where you give people a choice, usually hypothetical, between an immediately available reward like $100 today versus $300 tomorrow. So most people then say, I'll take the $300 tomorrow. You keep pushing the $300 back in time. At some point, people say, forget it. I'm not going to take the $300 a year from now. I'll take the $100 today. You can do versions of this with rats. In fact, the research began initially with rats. And people say that this is an example of how drug addicts don't have a good capacity to delay gratification. And I actually think it's a bit different. It's more complicated than that, because there's giving somebody a reward or some choice where they know what they're going to get. Whereas sobriety, at least initially, people don't know what they're going to get. And the substitutions, they don't know. It's vague. They have to figure out what's going to substitute. And I think that actually has a lot to do with relapse, because I know being obliterated has its consequences, but I also know what I can get out of it. Whereas you're telling me, wait for the long term, go to a meeting, and I think that's not. It certainly is never going to give the same, at least initially, never going to give anything like the pleasure that they got from using. And so they're competing, something vague with something that's known. And it's not the difference between waiting for $300 a year from now, because you know what $300 is going to buy you. It's just it's not worth waiting for. It's more like $100 today versus some larger amount of money later in life that will pay off.
What's interesting, a lot of those rodent studies do show that when you chronically expose an animal to a drug, you can make them more impulsive,
right,
as measured by these delayed to discounting type of paradigms. But the real problem is the impulsivity towards the drug, and that's not what they're actually measuring. They're measuring impulsivity to other things, natural rewards.
Right.
So I always wondered what it would, obviously it would probably produce similar results, and that would be the focus of Target, is impulsivity towards the drug. You might not become overly impulsive towards other things, but
right,
you are maybe towards taking the drug.
Yeah.
I wanted to ask two questions. One is, if there is any validity to the unpleasure or distress theory of Kantian, then you are erasing the pleasurable memory. But the distress, the unpleasurable memory, or the traumatic, or whatever, the selflessness, etc., you're not touching that. So why wouldn't that keep the person then restart the same thing? Doesn't have a memory of the pleasure. He very soon finds out by trying some other drug and says, gee, this is great. So now it starts a new one. So I wonder how you deal with that. The second question I had is that I don't imagine you have found out, or maybe you have, that some rats are just more prone to becoming addicted than others. But humans obviously are. Some, people can have a couple of glasses of wine all their life and never become alcoholic, and others immediately go to 3 martinis, and then the martini is vodka for breakfast, and so on. So there is a difference, and I wonder if you can comment on what you think that is about, and what the difference is there, whether there are genetic components, whether there are other reasons for that.
So in terms of the memories, actually different types of memories can be disrupted. So if we know which is or are the memories that are connected to why those individuals seek the drug, then those are the ones that we want to target. So it's not just pleasurable memory that can be disrupted, but also aversive or unpleasurable or different types. Because the basic mechanistic subsets are similar, so we just have to identify.
You wouldn't know that. That's what I'm trying. I know you. Right. Once you are in the business of disrupting memories,
we disrupt.
I assume you can take your pick.
Yes.
But in the work you are doing, you are disrupting the pleasurable memory of that particular addiction.
Yes.
And that's a different way of looking at it than the other hypothesis, which is really what is pushing them is the distressed memory, the painful memory. So you don't really have that in rats unless you traumatize the rat and the rat became addicted.
Exactly. You can recreate in rats whatever is the aspect of the memory that you want to disrupt. Now, obviously, in humans, it's much more complex because there is a complex history. There is time with the complex history, and reproducing all that in the animal model is very difficult, because then it goes to the individuality issue that you were talking about, and everyone responds differently because of their history and because of their genetic components. So there are both components. It is known that addiction is influenced strongly by genetic components as well as by the history. Meaning if during development they have experienced strong stresses or prolonged stress, both humans as well as in animal models, they are much more prone to addiction. So it's obviously a very complex issue to deal with.
Yeah, I'm very glad that Cristina said that humans are more complex than rats.
Sometimes.
That's debatable.
Sometimes.
Depends on the person, but there are those people. What I'm thinking of is that there's also a pleasure in being free of addictive substances. In recovery circles, it's called what is it called? I can't remember now. It's called the pink cloud. Oh, yeah. Suddenly your mind clears. You're not subject to this constant preoccupation with the substance and how to get it and how to use it and how to get it into your body and so forth and so on. And you feel wonderful. You feel strong. You feel powerful. You feel everything else. It's also a very dangerous time in recovery because you can then become overly confident, and you don't realize that the other thing is lurking there, ready to
hijack.
To come back again, right? One of the concepts that we use, which I think is very helpful, is the beast concept of the addiction. That it removes it from the center of the person to over here. It's the beast in you. It's like the Dr. Jekyll and Mr. Hyde idea, you see, that it's waiting there to pounce on you, so that you need to be constantly aware of that. In any case, there is a strong incentive to have your mind clear and to feel good, not to feel sick, not to feel hungover, not to feel that down when you come off cocaine, for instance, all that kind of thing. So that's all.
Well, then also just as the issue of memories, in the sense that I know that there are a lot of people who, to augment their recovery, will write down, the benefits that I got from using, alongside all the hell that came along with that, and so they try to force themselves to remember and be cognizant of all the difficulties and the consequences of using. So if I went out and I had a great time with my friends, but I ended up in a hotel and blew all my money the next day, I have to remember that as a possibility. So, I mean, that would be an interesting. To me, the memory issue is also clinically interesting. How do you get people to remember the bad times, the bad consequences, not just erasing the possibility of forgetting that you enjoyed this, because maybe someone in an operant world could then stumble back into a bar and say, "Oh, this is nice again." But
it also eliminates, strikes me, the possibility of the pleasure of coming to deal with the obstacle. In other words, part of the profundity of the experience of going through something difficult is the engagement in it, and that becomes a pleasure in and of itself. That you can, so that if you're removing a part. I mean, I'm not discountenancing the fact that obviously this is a very interesting part of research, but that it's like when I've heard a lot about these. I have to say, I haven't had a drink for 22 years. I don't drink anymore, and I'm somebody who could. I mean, the whole concept that you would take away from me, the premise of doing all this kinds of interesting work around the project of not drinking, would be taking away a gigantic, wonderful endeavor of human existence, which is coming to terms with displeasurable activities on people that were highly sensitive to displeasure. Which is a hugely interesting. So many of the behavioral therapies that they propose are kinds of ways of narrowing the whole concept down, and mechanicalizing it, and that's what that sort of is what is sometimes distressing to me. Like as someone like me, I would never. I mean, I'm not interested at all in having a few drinks. The whole idea of these kinds of therapies, they just come along and say, you could possibly have 2 drinks. I've never in my whole life wanted 2 drinks. I love to drink. I'd love to drink. I could just go out and just drink myself to death right now. But then I'd have to all the other possibilities would be eliminated from my existence. Right. So I've always been kind of circumspect about those kinds of approaches, but and I respect all the kind of hard work that's gone into thinking about this.
Shall we open to the questions? So we
come to the microphone if you want to.
Yes, please do that.
And say who you are.
I'm Jane Goldberg. I wanted to know, have you all ever dealt with love addiction? Love addiction.
Love addiction.
Do you mean sexual addiction or love?
There you go.
Emotional love or fantasy or obsession, and how do you distinguish between obsession and addiction?
I've never
Because
dealt
there are
with it in my
groups
practice.
there are many groups that are based on 12-step programs.
I've actually never dealt with it in my practice. I mean, some of the people in my department deal with it in terms of trying to address stalking issues, but never had to deal with it.
This psychiatric diagnosis of erotomania, for that. So it's not really classified as an addiction, but as a different
Exactly. I don't think it's defined. I mean, it's generally included in the addiction field, but it's not really defined as an addiction, I think, because what is missing is when the object is removed, the substance in the case of the addiction, then there are all sorts of symptoms that come up to take the substance in again, which is missing in these types of more obsessive type of responses, behaviors. I think that's the difference.
There's no physiological withdrawal.
Yeah.
I think I'm sorry. Whoops. I just wanted to comment on. To me, it seems that love is the exact opposite of addiction. Addiction is to taking something into yourself, and love is giving out something from yourself. There's people who I know who I treat in addiction. They've forgotten about love. Mm-hmm. They don't experience it. One of the great joys in seeing a person in recovery is that they become, instead of taking in people, they become giving out people, and they restore love to their life experience. So I don't think the two have.
But in those conditions, when you scratch the surface of the love, there's a great deal of aggression and rage.
Oh, yeah.
But it manifests itself as repetitive, falling in love and obsessing about the love object.
I see.
Which could mean taking.
Well, maybe you're talking about two different things.
The way you are describing love is different. I mean, as I said, that's a psychiatric condition, essentially, where love is the surface of something that is behind it, which is usually much more aggressive in nature.
Yeah, you're talking about a more mature.
You're talking about the real love, and that's not real love.
Yeah.
Oh yes, I was talking about real love.
Well, my question is about going back to addiction. I think we've talked so much more about the treatment of the actual issue, getting rid of the problem. The cause of the problem, I think, is the biggest issue here, and something that has not been really addressed all that much, in my opinion. And I think, from my observations, I'm kind of a world citizen. I've lived in many countries throughout, and it appears to me that the cultural context is the key distinction as to the severity of the problem. The Puritan societies typically, they have drawn the line between the evil and the good, and they've taken things to the extreme, whereas it was already mentioned here earlier, the moderation is the key. And if the society does not put the cultural stigma on people as to what's good and what's bad, it does not advocate for either or in any shape or form. The connection of the memories and the strength of those memories of not being stigmatic, being strong as really, really morally right or wrong, they become sort of very settled and much easier to break out of or break into, just because they're not. It's not part of your upbringing. It's not part of your everyday living. You're not really emerged into this daily reminding of what's good and what's bad. So the whole concept of good and bad, I think, is fairly wrong.
What society, by the way, do you think of as a society which conduces to moderation?
To moderation, UK was brought to an example. Drinking is part of the culture. Russian culture, for example, is part of the culture.
But where's the moderation? Where do you find the moderation?
The moderation, I think the moderation is something that you will find for yourself. Everybody will find what's good. You know, if it makes you feel bad, eventually you will realize that maybe you have some good friends that will say, you don't smell that good. Do you want to just address that? I mean, it's really more, but if you have that stigmatic thing, and the memory, the strength of memories, I think is the key here. And the culture does impose the stigmatic value to those memories and become very strong and very hard to get rid of or get into, as I was saying before. So that's just my opinion. I just wanted to bring that up. So.
I think that's a good point, though. I mean, even within our continent here, the ideas of alcoholism in Canada are very different to the ideas of alcoholism here. And, you know, one that drinks a six-pack there might not be considered to have a problem. So.
Well, in France, they did use it was a problem when people for breakfast would have a Calvados on the way to their work.
Maybe not.
Gradually, they came to the conclusion that it does represent
But you see,
the problem.
I'm not sure it is a problem. It depends on the person. Like I personally don't have any moral feelings about drinking or not drinking, but it seems to be like something where you notice a different type qualitative effects in certain kinds of people. Like if someone like me had a Calvados on the way to work, there's a purpose in it. But there are people who live, like for instance, there are truck drivers who have a regimen of they'll go have a shot. You know, and I've met people like this, and they don't strike me as being typical of the types of alcoholics that I would know about. You know?
Hi, my name is Efia Ronovich, and I'm a director of Cognitive Lab at Columbia University. I'm a clinician myself, and I do research, and I would like to comment on everybody's talk here, from Bill and Dr. Alberini, both of you. Well, first of all, I'll start with exercise, and I have very bad memories. I took some notes. As a matter of fact, NIDA, the National Institute for Drug Abuse, Dr. Volko last year in her meeting announced that we would like, and she put it out to the research community on addiction, to start studying exercise and how exercise can be used in the treatment of addiction. I also want to say that addiction is a very, very complex problem. It's not one thing, and there's not one theory. And it's not just culture, it's environmental, and it's genetic, and it's very, very complex. Also, not all substances are the same. I myself treat patients with cocaine addiction, mostly the stimulants, and marijuana and alcohol. I don't treat patients with heroin, for example. They're a different class of patients. Also, patients are very different from, although addiction hits all sorts, from all types of SES, it really depends on who you see for patients. If you see them from on the Upper East Side, Lower Manhattan, in the Bronx, or in Queens, they're different people. As far as memory, I am very pleased to tell you that right now I'm conducting research in my lab on humans. I'm interested in cognition, as I said, and in memory. And we expose cocaine patients to memories with scripts, to their own memories of the high. Because what brings them then for use and to relapse, it's not memories of bad memories. Usually patients come and say, "Doc, you know, I've been clean for a week or two, but what's so hard for me to get rid of is the memory of the high." They use it for the one split second. No one uses cocaine or any type of drug to feel miserable. They want to feel good, and they remember the good feeling. So we expose them with their own scripts. I give them beta propranolol, beta blocker. I don't know yet if it does something, because it's pretty much what they do in PTSD.
Similar, yeah.
But there are mixed results, so we don't know how to treat them yet. And we'll see. We're still running this, and I'm very pleased to see you here today, because I'm interested in those memories. So one of the questions to you that I do have, and I don't know if you can answer because you work with the rodent, but by the way, my plan is, or my mission, or what I would like to do, is to weaken these memories, not to erase them. I think that erasing memory will get us researchers to very hot spots, and not just in addiction. Think about erasing memory of people. If you can bring them back the memories and use all kinds of substances to erase it. All I want to do is to help those patients to weaken, to make those associations loosen, if you want, so they can control them better. Now, the question is about networking of memory. Is the memory that you're trying to erase are very, very specific and local, focal, or do they have to be erased, like if the scripts needs to be very specific, or one scripts then can generalize to other association? Because when people use, they have many triggers. They can see the place, people, right, situations, and all those can be trigger for their addiction or for the relapse. So the question is, what kind of memories we should focus on, and so.
Yeah. So those is beautiful and great to see you here. It's exactly those are the questions that we're trying to address with the animal research, because those are relevant for clinical applications then. So just to comment about the propranolol, there are actually already studies in rodents published with propranolol in this type of memories, drugs in these memories, and they didn't see much of an effect. Mm-hmm. And in fact, as you mentioned, the results with propranolol are mixed. Mm-hmm. It's not clear yet if they are very effective. So stay tuned. Hopefully we have more in the future. Concerning the types of memories and the strength or the parts of the memories that should be or can be targeted, those are very important and beautiful questions. For example, in the traumatic memories, we are looking at whether these treatments, they decrease the emotional part of the memory, but they leave the cognitive part intact, which that will be what we want to. We don't want to erase the memories, but we want to take away the bad feelings attached to that. And so we are trying to dissect that. I didn't go into those details because I thought it was, but those are exactly the question of how to go further in this type of approaches. So we don't know yet. I don't have the answer yet. And to comment about the memories induced by drugs, yes, it's true. Most of the time, the issue is that they relapse because they feel the craving and this impulse to get high. Even though then in chronic state, sometimes addiction is also to take the drug to get away from the withdrawal. So there are also those, but yeah, I agree with
the last thing is, I think it's a challenge here because it's the New York Psychoanalytic Institute.
No, we just happen to be in the building.
Okay.
And I happen to be a member of it. Don't let that...
But I think it's a challenge to Bill, and Bill knows we are basically from the same school and almost same alma mater. When we talk about treatment for addiction, right now there are basically 4 psychosocial interventions that are evidence-based. It's the cognitive behavioral therapy for or relapse prevention that started with alcohol. Very powerful, efficacious treatment, which also helps the patient to have coping skills and to substitute one type of behavior or not the so good behavior as the addiction to other types of behavior. There's motivational interviewing that is very helpful. And as far as prognosis, we have research to show that the commitment language of the patient in the session is a good prognosis. So patients who come, and we have psycholinguistics that do analyze the verbal statement of the patient. We just published on it, as a matter of fact, and we do show that good prognosis is someone comes and say, I want to stop, and they're serious about stopping, this patient probably, most likely will stop. Mm-hmm. So CBT, MI, and...
I have a question for you. I just want to interrupt real quickly.
Okay.
With MI, I haven't followed the literature as much recently, but there was some studies where they were beginning to measure therapist language in addition to client language. Have they found any measurable effect of therapist language on that as well?
Good question. I'm not so sure if you're talking to Paul Amorine, who works with Bill Miller and looked at yes, but I think we're still looking at the patient's language and how basically the therapist can induce this type of commitment in the patient. So I encourage you to look it up in the literature. Again, it's 2008, it just was published. So that's prognosis, commitment language, very important in addiction, how the patient commit. And there's the 12-step facilitation program, also found to be efficacious in addiction. But there is very little, or almost none, data, and I'm talking about evidence, empirical evidence, that psychoanalysis or psychoanalytic intervention is helpful for the addiction. So I challenge anyone, and
it's not my specialty, but Bill here.
Yeah, I challenge Bill here to do a clinical trial on and to compare psychoanalytic intervention to CBT, MI, or any combination of the above, and to see if it's really efficacious. One of the problems we have with patients with addiction is that over time, with prolonged use, and again, it doesn't matter if it's alcohol, it doesn't matter if it's cocaine, marijuana, definitely, they have cognitive impairments. And a patient who comes to treatment after long-term use, it's very hard for them to sit in 1-hour sessions, and definitely they don't really remember what the therapist said in the beginning, and it takes time. So to take someone for a long-term intervention where you know that they're NC in the first few weeks, and we have a lot of attrition in the first 4 weeks. We have close to 50% of all patients drop out of outpatient treatment, and there is a reason for that. So again, I think that it will be great if we'll start seeing more of evidence-based data that psychoanalytic intervention help in the addiction. I'm not saying it doesn't, but I just say I would like to see the data. And thank you.
So I will address what I do know about that issue. We'll actually address two issues of it. One is that there are a handful of clinical trials from psychodynamic treatment, supportive expressive therapy developed by Lester Liborski. Back in the 1980s, George Woody, Lester Liborski, Tom McClellan did a randomized clinical trial comparing supportive expressive psychodynamic therapy with cognitive behavioral therapy plus treatment as usual for opiate addicts, and they actually found that the supportive expressive therapy was by far the better treatment. They repeated the studies with Paul Christoph in the 1990s with a cocaine treatment for cocaine. They found that both psychodynamic and CBT actually were both equally bad. That there were some okay results for some people, but overall neither treatment was that good for cocaine abusers. Basically the same design, and what seemed to work best was basically traditional drug abuse counseling for cocaine abusers. No one really knows why this occurred. Although I have some thoughts. There was a randomized clinical trial of borderline patients who, I don't know if they were cocaine abusers or not, that was conducted by Robert Gregory up at Syracuse, that was published about a year ago, and that was compared to psychodynamic treatment with cognitive behavioral, and they found that the psychodynamic treatment was actually a little bit better.
What is supportive expressive? Is that in psychodynamic, you said?
Yes, yeah. Yes. Supportive expressive is using supportive and more inside-oriented interventions. Okay. And there's a handful of other stuff. There was also the meta-analysis on psychotherapy that was the first one that really kicked off the whole field of meta-analysis, published in 1980 by Smith, Glass, and Miller, did look at a broad range of addictions, specifically, and they didn't in the report, they don't tell you which addictions they actually looked at, but they actually found that psychodynamic treatments were as effective as any other treatment. Now, the issue of doing a randomized clinical trial, as you know, A, it's easy to say it. B, it's hard to get the funding, and especially in this climate, whenever I've called up NIDA, and I've gotten some funding from NIDA, whenever I've called them up and talked to a program officer, and they mention anything psychoanalytic, I have to wait for a few minutes before they catch their breath and say, why would you want to do that? What advantage is it going to have over what we already know works? And some of them are friendly towards psychoanalysis, but then getting them to be interested in funding a randomized clinical trial, and then finding the space. I mean, I have to find a place to actually run it, but that's actually the easier thing to do than getting the funding. So I would love to run a randomized clinical trial of psychodynamic treatments, but it's, I think, hard to just get the funding and get to do it. And also, just one other thing, I've also gone to the psychoanalytic organizations that do fund research, and unfortunately they have very little interest in funding drug abuse research.
That's certainly another issue.
So.
Yeah, I just want to add to that people that psychoanalytical approach or psychodynamic approach to recovery issues, if the person is interested in that, then it's probably going to be efficacious. If they're not, some people have what they call like a tin ear to that kind of a thing. They're not going to be benefited. But it's just like you have to want to get sober to get sober. You have to want to be good in order to be good. A lot of people, that's I just think it's very unhelpful to distinguish, to have a moralistic approach towards this thing, because once you say, well, it's good to be sober, then the person says, well, yeah, but I want to be bad. I don't. So it just isn't helpful. So if it works, if you're interested in it, it's going to work. If you're not, it's not. That's my feeling.
I think, Mark, you were next then.
Hi. You've talked about various pharmacological approaches to erasing traumatic memories, and I was just wondering if you could talk a little bit more about non-pharmacological approaches. I read somewhere of something called EMDR, and I was just wondering how effective that was as in terms of dealing with traumatic memories. I mean, where you can recall the event, but the emotions associated with it are dissipated. And I was just wondering how effective that was in terms of dealing with addiction.
Yeah. So I cannot comment on that because I'm not at all an expert on those type of approaches. We are more like interested in understanding with animal model the mechanisms of memory strengthening or disruption. So I cannot really comment on that. But there are non-pharmacological approaches even in our domains, and those are using new learnings to interfere with these memories. So the memories are recalled, and in the same time window, instead of giving them a drug, we're just going to challenge them with a new learning. And that can work too. Obviously, it's not as strong right now, but we have room for improvement and understand how to modify the protocols so that new learning is going to decrease the strength of the old memory. So it's possible.
I want to add to that. I don't practice or know that much about EMDR, but I am familiar with it as a process, which is to desensitize by re-experiencing the traumatic event in your life, and going back there and feeling the original feelings and thereby desensitizing to that. And I would say that it would be a highly effective technique if used in drug addiction. I use it not as a practitioner of EMDR, but adopting some of those principles. And I find it that if the patient is curious and willing to go there, it can be very beneficial.
is, since most of the discussion on this topic here and elsewhere is about people who become addicted and how to treat them, is there any work on either animals or people on those that don't become addicted and why they don't?
Yeah. That's a good question.
It's a very important point. Yes. Go ahead.
Certainly in animal models, they've started to address those questions. What they've done, usually it starts with human linkage studies, meaning that they analyze the genetics of a particular human population and they find a specific genetic mutation that correlates to an increased propensity, whereas the alternative mutation or lack thereof, usually those populations are less likely to. So what we've done in animals is to use bioengineering approaches to construct that mutation in the DNA, put it into a mouse, and then show those behaviors, and you've got nice laboratory control over that. So we've found at least, I think 2 or 3. The genes are called COMT, BDNF, and I'm blanking on the third one, but there are specific genes that we've been playing with. Obviously, there's other ways of doing it too, so it may not be a predisposition per se. A person without the mutation may also fall into an addiction, and there's other therapeutic approaches that have been used in neurological settings, like for treatment of Parkinson's disease. And this is where you've basically lost a cell population in your brain, and then you can use bioengineering techniques through viruses to replace that function. And the idea that in drug addiction you're getting altered function of brain cells because of the chronic exposure, it lends itself, obviously, much in the future, but lends itself to those types of approaches, maybe replacing a particular protein in a cell by these bioengineering techniques may be effective in preventing relapse. We don't know that yet, but...
Also, just to address the issue of research in humans, going back really beginning in the 1960s, Jack Block, who was a researcher out in UC Berkeley, started a longitudinal study, and he was looking at what he called ego control, which most people would refer to as self-regulation. And he found that people as young as 3, if they demonstrated poor self-regulation, that predicted poor self-regulation often in adolescence on average, and that predicted a tendency to a significant tendency to become more likely to become addicted if you experimented with drugs, and that people who had good self-regulation could experiment with drugs and not have a problem. They could get the benefits, enjoy them, take them or leave them. People who didn't have that good self-regulation capacity, unfortunately, could not take them or leave them. They took them because it helped them regulate. And so that some of the longitudinal research.
Yeah, that's an idea for the next roundtable, right? So environment versus genetics.
Sorry, on that note, that's self-regulation. My question was going to be, have you sort of noticed a general trend of addicts before they become addicted to be indecisive people? And would that self-regulation tie in with indecision? What do you mean by self-regulation?
The way Block defines it is kind of interesting. He doesn't make it as indecisive. He basically sort of looks at personality as having sort of two main sorts of styles. So there's one he calls the over-controlled style, and one he calls the under-controlled style. And the over-controlled style would be, when it's pathological, would be akin to someone who has obsessive-compulsive disorder, paranoid. When it's not pathological, that it would be sort of a rigid kind of a character, rigid sort of style. So it's someone who likes order, but it's not pathological necessarily. The under-controlled style is more tending to be impulsive. These are not necessarily pathologies. What he says is that the person who has poor self-regulation, poor ego control, is that individual who, let's say they have an over-controlled self-regulation style, they can't not be rigid. So if the situation calls for flexibility, they can't be flexible. If the person who has the under-controlled style needs to be organized for a particular reason, they can't become organized. They're continuously impulsive. That's where the pathology is. So for him, it's this autonomous function that's dysregulated or absent or minimized, and so that leads to the substance
Who was that? Sorry, who? What was the name?
His name is Jack Block.
Jack Block.
Yeah, he's at the University of California, Berkeley. He's emeritus, but you can find his stuff.
Thank you.
Any other questions?
All right.
If none, then thank you very much, everybody.
Thank you.
Further information about our programs and a complete archive of past Philippides events is available at philippides.org.